Good morning, everyone, to our Buncke Clinic Virtual Visiting Professor Series. I am Bob Aksafa, and along with my partners, Greg Buncke, Rudy Buntic, Andrew Watt, and Walter Lin, we have the distinct honor and pleasure this morning of welcoming a true giant of Italian microsurgery and hand surgery, Professor Roberto Adani from the Modena University. Professor Adani is chief of the Department of Musculoskeletal Surgery and chief of hand and microsurgery in Modena, and he has been kind enough to be our virtual visiting professor today. A little bit of background, Professor Adani is a native of Modena, so born and raised. He was born in the beautiful city of Modena, which is in the region of Emilia-Romagna, the land of fast cars and slow food. It's an incredible place. If you have not been, you should definitely go. He obtained he got his MD degree from the University of Modena, did orthopedic surgery there and hand surgery, and subsequently did a microsurgery fellowship at the National University Hospital in Singapore with Professor Fo. He was the department chair, the head of the Department of Hand and Microsurgery at the University of Verona until 2015, until he moved to Modena in 2015 and became the chief of musculoskeletal surgery and hand and microsurgery. He was the president of the Italian Society for Microsurgery from 2007 to 2009, and he was the international delegate, or one of the delegates, to IFSSH, the International Federation, from the Italian Society for Surgery of the Hand in 2015 to 2017. He's published over 220 journal articles, 28 book chapters, and he delivered the Venkataswamy Lecture at the Indian Society for Surgery of the Hand in 2013. And he was also the international guest lecturer for ASSH back in 2017. So clearly a man who has accomplished quite a bit, and you're about to see why we really were excited to have him as a speaker for us this morning. Professor Adani, with that, I wanted to thank you again for being with us. It's truly an honor to have you here. And I'm going to make you give you presenter controls so that you can share your desktop with us.
Okay, okay. 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 Is it okay, Bubak?
Let's see. Hasn't come through yet, at least not for me. Can anybody else see Dr. Adani's screen? I can't see it yet.
Not yet.
Yeah, we don't see it yet, Roberto. And your webcam is paused. I'm not quite sure. Aha, there it is. Perfect.
Okay, is okay. Now
it's
now
fantastic.
It's okay.
Yes.
Okay.
Excellent.
But thank you so much for your very nice introduction, and thanks so much for inviting me. It is really a great pleasure. And for me, it's like just to come back to San Francisco, because in 1991, I came for 1 month to the Buncke Clinic. And at the time, there was Harry Buncke, Leonard Gordon, and Stephen Mattes. And I remember it was a fantastic period for me to stay in San Francisco, and was a place for really great master of microsurgery. Today, my speaker is about thumb reconstruction. The functional thumb is one of the most essential components of hand functionality. And we have to remember that loss of the thumb accounts for loss of 50% of the entire hand function. In the late 19th century...
Roberto, I'm very sorry to interrupt. Just real quickly, down below on the bottom of your screen, if you click on hide, you should be able to hide that little bar from the GoToMeeting app. Yes, right there.
Okay.
Excellent. Thank you so much.
Okay, thanks so much.
Yeah.
In the late 19th century, the Austrian surgeon Nicola Doni introduced several original ideas, including the tubed pedicle flap and the toe-to-hand transfer to substitute for amputated part of the thumbs. In a 5-year-old child, he transferred the second toe to the hand as a pedicle flap. And during the 60s, Harry Buncke began with his experimental works on primate a new microsurgical thumb reconstruction technique. And beginning in 1996 with John Cobbett, microvascular toe-to-thumb or toe-to-finger transfer came into clinical use, and it remains one of the important approach for thumb reconstruction. This was the first thumb reconstruction which was done by Cobbett in UK in 1960, published in JBGX in 1969. And over time, surgeons have focused on thumb reconstruction by developing a variety of techniques, including traditional techniques, for example, osteoplastic reconstruction with neurovascular island flap, osteoplastic reconstruction with the radial or the posterior interosseous flap, politicization, distraction lengthening technique, and more recently, we published osteoplastic reconstruction with a perforator flap. Also, another possibility is to use prosthetic replacement, introduced by Goran Lundborg in 1996. And we use this technique in our department in patients that refuse microsurgical reconstruction. And the prosthesis can deliver some tactile sensation because of this intimate association with the bone of the digit. Litter in 1966 introduced the reconstructor criteria for thumb reconstruction: length, position, stability, mobility, strength, sensibility, everything without pain. And in 1980, Wayne Morrison from Melbourne introduced a new concept, a novel reconstructed concept that is the new thumb should be aesthetically normal. And we have to remember that the aesthetic of the hand are valued second only to the face, and reconstruction would be considered even more successful if an aesthetic appearance could be obtained as well. And free flaps from the great toe are an acceptable procedure for reconstruction of absent or partially amputated thumbs. And considering the criteria of Litter and Moore and our experience, we an optimal thumb reconstruction should meet three main objectives: restore thumb function, brick rate is aesthetic, and also this concept is very important, meaning minimize donor side morbidity. And various surgical techniques have been reported, and opinion different as to which technique represent the best solution for each level of amputation. It is possible to use a completely great toe transfer, the second toe transfer, the great toe wraparound transfer, or the trimmed great toe transfer. And it is also very important the patient selection. And decision on surgical method used depends on age. In our department, the maximum age is about 60 to 65 years, health condition, occupation, level of amputation, functional demand expressed by the patient, and cultural background. Most surgeons consider a thumb amputation with an intact MP joint to be an ideal candidate for toe-to-thumb transfer, and politicization is reserved for patients with a more proximal absence and without a stable carpal metacarpal joint. Furthermore, a considerable number of patients in countries, for example in Italy, where open toe shoes are worn regularly, the patients are reluctant to donate tissue from the foot. Women often refuse the removal of their toes, and the abnormal appearance of the donor site is a main reason why a patient rejects this option. Consideration of all these elements may improve the outcome for microsurgical thumb reconstruction, or even lead to the choice of an alternative reconstructive option. The patient needs to be evaluated pre-operatively regarding level of amputation, joint mobility, tendon muscle function, and sensibility. And the patient should express a strong desire for reconstruction and must understand and accept the risk of operative failure, donor side morbidity, and the functional limitation on the transferred toe. And the vascular anatomy. Vascular anatomy is very important. The dorsal arterial system to the toe is used in almost microsurgical transfer of tissue to the thumb. And the use of dorsal arterial system with a large artery and this long pedicle considerably diminish microsurgical difficulty, despite the great amount of anatomical variation of the first dorsal metatarsal artery. There are different types of dorsal metatarsal artery. Type 1A is dorsal to the interosseous muscle, like for example in this case. Type 1B is within the interosseous muscle, like in this. Type 2A, the artery is duplicated. And for example, in a case like this, we use the dorsal system, and also we take the two communicating branches between the dorsal and the plantar system, ionostomose this small branch to increase the flow for the toe transfer. Type 2B is below the interosseous muscle, like for example in this. And finally, type 3 can be absent or hypoplastic. This is absent. This was hypoplastic and was ligated, and I used the plantar system. Wu Wei introduced the concept of retrograde dissection of the vascular pedicle into harvest, and the dominant vascular pedicle is identified, avoiding unnecessary dissection. This type of dissection has one big merit. In case where a lengthy pedicle is not required, retrograde dissection avoids harvesting of a proximal vessel. Another possibility, another solution is this solution proposed by my friend Dr. Wang from Jinan, China, to release completely the first dorsal interosseous muscle. This is the video, this is the muscle, and the possibility is to move the muscle completely and to cut the muscle at this insertion to see completely the vascular pedicle. There are some surgical difficulties because, for example, the type 2A, when the artery is duplicated, and the type 3, when the artery is absent or hypoplastic, are the most difficult for surgical dissection. Patients need to receive Doppler ultrasound to study donor and recipient vessel. Usually, we don't employ computed tomography and angiography, only in very selected cases when there is a history of previous trauma and there are congenital anomalies in the foot. Start with the different level, amputation at the base of distal phalanx or through the IP joint. Thumb amputation distal to the IP joint does not cause any functional disability, and this level of amputation does not necessarily require microsurgical reconstruction. Depending on patient lifestyle, custom, and cultural background, there may be a high demand to improve appearance and more refined function. In selected patients with strong motivation, the loss of nail, sensible pulp, or the fine to nail pinch may be indication to transfer part of the phalanx of the great toe. The base of the distal phalanx joint can be treated employing many techniques. The mini wraparound flap, the thin osteonicocutaneous flap from the big toe, osteonicocutaneous flap plus permanent flap, great toe partial nail transfer technique, or the onycho-osteocutaneous defects for thumb reconstruction with partial hallux transfer proposed by Del Pinal. This method all use a custom-made osteonicocutaneous flaps, different method but very similar. We use the mini wraparound flap. In all cases, ipsilateral hallux was the donor side. The insertion flex to hallux longus should not be violated. The entire nail in most of the cases were harvested. A longitudinal osteotomy may be used to reduce the bone, and pulp from the medial aspect of the great toe is used, and the flap is based on the dorsal or plantar vascular system. And in all cases, the ipsilateral hallux was the donor side, and a segment of the lateral or medial digital nerve is included. Bone fixation was done with 2K wires, and a narrow medial flap about 1.6 cm is preserved for closure. This was a case with distal thumb necrosis after failed reimplantation, and this was the final reconstruction. Was in this case it is also possible to obtain some movement of the IP joint of the thumb or side. Severe burn injury of the hand, and this was treated by releasing the scar contracture, open the first web space, and finally was thumb reconstruction, employing the mini wraparound flap. This was the aesthetic appearance of the new thumb compared with the contralateral, the donor side appearance. This was the end before treatment, and this was the end after final treatment. Amputation through the IP joint. In this case, also the first web space was deepened, and this was at the end of surgery. It was stopped. This was after a short time period, after 40 days, and this was the final result 4 months later with the new thumb compared with the contralateral, the donor site appearance, and X-ray result. And index finger the second way was amputated to have a more acceptable and cosmetic appearance, and the donor side. It was a case of severe circular saw injury resulting in distal thumb necrosis, including the dorsal skin over the MP joint. After debridement, I decided to use a dorsalis pedis flap in combination with the toe based on the same vascular pedicle as described by Wayne Morrison, PRS, in 1899. This was 2 flap, only 1 pedicle, and this was at the end of surgery. I was not able to cover everything with this flap, and for this reason, in most of this type of case, I use also Integra to have this type of medication, and also I use Integra at the donor site, and after 3 weeks Integra was removed and skin graft was used, and in the thumb and in the donor site, and this was the final result after 5 months in the thumb and the cosmetic result in the foot. This was thumb avulsion at the base of the distal phalanx. Young boy, 8 years old boy. This was old cases performed using this mini wraparound flap, and this was the final result in the thumb and the donor side result. This is a very interesting technique proposed by my friend Dr. Wu from Korea, published in PRS in 1998. And this is the great toe partial nail preserving transfer technique. And this technique has the advantage of preserving some portion of the great toe's nail after flap harvested. And it is possible to have this small nail in the donor side that is not so bad. And I use this technique when there is a big discrepancy between the thumb and the great toe, and the cosmetic appearance of the nail is in the circumference. There are big difference. In this case, I don't like to harvest completely the nail from the great toe, and I reduce the aspect of the nail, and I preserve some part of the nail. This was the surgery, and this nail was rotated about 90 degrees. This was at the end of surgery, and in these cases, before doing thumb reconstruction, I performed first web release, employing a posterior interosseous flap, and this was the result after 4 months. This was the end before, and this was the end after. The results obtained with these techniques are good, both functionality and aesthetically. And this technique result adequate length, good pulp, and appearance of the nails to the contralateral thumb. This partial great toe transfer offers cosmetic reconstruction. Moreover, the nail represents a cosmetic as well as the functional advantage. This was a nail deformity and pulp atrophy of the thumb, and this was reconstructed with a mini wraparound flap, and the appearance of the nail is quite similar to a normal nail. We have to remember the cosmetic role of the thumbnail should not be underestimated. And the donor side. Some patients may have a functional reconstructed thumb, but they underuse and hide if the nail is not present. And the function of the distal phalanx are not completely transferable to the remaining stump of the proximal phalanx. In fact, the terminal phalangeal segment constitutes the most vital part of the thumb. Brain lie the pulp, nerve receptor, fingerprinted skin, and the nail. This level of amputation, we have to remember, does not necessarily require microsurgical reconstruction. A 2 cm long lesion offers a thumb long enough to maintain a good function. Distal thumb reconstruction with toe transfer is more for appearance than for a function. And quite often we use a veiplasty at minimum 1 year after primary reconstruction to increase the aspect of the pulp. These are our result about the motility, the sensibility, and mild foot comfort is possible, can be present, but is not frequent. And we have always used the allus as a donor. The second toe in my department has not role for distal thumb reconstructions. Thumb pulp reconstruction, the technique is the great toe pulp flap described by Edie Buncke many years ago. This was a case with a malformation involving all completed the pulp, and this was reconstructed with the transfer of the great toe pulp. And the shape and texture of the pulp are very similar to those of the normal thumb. But we use this technique only for large defect and very large defect. There are some other alternatives for thumb pulp reconstruction, maybe still the little flap using with the modification proposed by Hirose Buckler, the kite flap, the dorsal nerve flap, the radial mid-palmar island flap. Dorsal thumb amputation. The technique employed in this case is the custom-made technique described by Fu Chan Wei and Dr. Wu. Covering dorsal thumb defect with an intact volar surface can be a challenging issue, particularly when multiple tissues are involved simultaneously. This was a case of complete dorsal thumb necrosis due to hot press injury with an intact palmar skin after debridement, the flap, and the final surgery, the donor site, and the appearance of the thumb with the contralateral and complete integration between the dorsal and the volar aspect of the skin. This was another case quite similar with unstable dorsal skin of the thumb following groin flap coverage, but the patient was completely was not satisfied with this technique. The skin was removed and part of the skin taken from the dorsal aspect of the foot of the thumb was used to cover the donor side effect. This was the result of the nail and the donor side. Cosmetic result is satisfactory because the quality of the skin and nail on the dorsum of the great toe is similar to the natural thumb. Thumb amputation at the base of the proximal thumb. Everyone knows the Morrison around flap described by Morrison many years ago. This was the first case of round flap technique. This was done by Wayne Morrison and introduced initially the wraparound flap technique, which used the boneless pulp of the great toe and is nail wrapped around a bone graft harvest from the iliac crest. But the problem was the bone reabsorption, and the original technique was modified with harvesting the wraparound flap together with a bone fragment of the distal phalanx. And the bone graft harvested from the iliac crest is now placed between two vascularized fragments, thus reducing reabsorption of the bone graft. This was a case. Also in this case, the first web space was open with a posterior interosseous flap. The bone graft was placed between two vascularized grafts with complete integration of bone graft. And this was the cosmetic result. And this technique required bone graft for support. IP joint cannot be reconstructed. This is another similar cases using the wraparound technique, the classic wraparound technique described by Wayne Morrison, with complete integration of the bone graft placed between the base and the distal part of the bone graft harvested from the great toe. This was a case of 13 years old girl. You know that probably everybody know that this technique is not useful for a child. In this case, it was 13 years old girl, and I decided to use this technique, and the bone graft was overestimated, and this was the final cosmetic result, the final X-ray result. But we have to remember that the wraparound flap is not useful for thumb reconstruction in children because it does not offer any potential for growth. Avulsion amputation treated were and referred to as 20 days after initial trauma, bone graft, and wraparound flap. In a case like this, I was not able to close directly the skin. For this reason, also in this case, I use the Integra, and after Integra was removed, skin graft was placed, and this was 1 month after surgery, and the final cosmetic result, donor side result, X-ray result. Chinese surgeon suggests a modification of the wraparound flap that preserve a plantar triangular flap. It's just a little modification to increase the donor side result. I use also this technique, but I believe that there are no big difference between the original technique described by Wayne Morrison. This was the case. The bone graft was the final cosmetic result, the donor side result, and X-ray result. The wraparound transfer, the hidden indication to this procedure is thumb degloving injury with preserved skeletal elements, or in case of thumb amputation at the middle of the proximal phalanx and part of the bone distal phalanx should be preserved in the flap. For example, this is a case of degloving injury. Complication. The drawback of this approach are that the reconstructed thumb has limited range of motion and resorption of the bone graft may occur, like for example in this case. And flap including bone harvested from the terminal phalanx of the great toe have a limited risk of bone resorption compared with the first technique in which Wayne Morrison used the wraparound flap without the bone. Now when we use this technique, we include every time the bone. And the other problem is the donor side. The donor side can be treated in different ways, with a cross-toe flap, as described by Hamilton from the group of Melbourne, directly shortening the great toe that is quite popular in Europe, or maybe to cover the donor side using Integra or other similar technique. This was with Integra, or using free flap. This is more popular in Asia country. This is a case with done for Dr. Wu from Korea, or this other friend, Dr. Wang from China. They are very skilled, and in every time they also are very good to cover also the donor side defect. This employ a very good team of microsurgeons because are 2 free flaps done in the meantime. Thumb amputation at the base of the proximal phalanx can also be with a great toe transfer. This was a submalignant melanoma of the navel area performed by Dr. Wu, and in this case he preferred to harvest completely the great toe, and he was able to obtain good motion of the new thumb. I believe that this technique, the whole great toe, can be transferred when the great toe is similar in size to the thumb. There are some other alternative methods. This is the bipolar lengthening technique described by Fouché from France, and this technique is a combination of first web deepening and distal lengthening by a transfer of pulp, nail, and bone harvested from the distal phalanx of the toe. And the first web space is deepening using the Ostrowski technique, and Fouché in the original technique avoids iliac bone graft, but the thumb is very short, and I prefer when I use this technique to put a small bone graft. An alternative, when some proximal phalanx of the thumb remains, it moderately lengthens the thumb and deepens the first web at the same time. We use also the metacarpal lengthening and mini wraparound transfer. For example, in this lady, initially the thumb, the metacarpal was lengthening using this external fixation, And after 2 months, a mini wraparound flap was performed. The thumb was just quite enough. The length was not so bad, but the patient required also a more microsurgical appearance, a more appearance of the new thumb, and we decided to move to the mini wraparound flap, and this was the final result. Level 3, thumb amputation of the MP joint. Two main techniques, the weight treatment toe technique and the total great toe transfer. The weight treatment toe technique was described by Fu-Chan Wei, and the total great toe transfer was described initially by the group of Harry Buncke. The weight treatment toe technique, circumferential measurement of the intact thumb are reproduced on the great toe. The resulting medial flap represents the extension, and the medial joint flap composed of the periosteum, the medial collateral ligament, and the capsule is elevated horizontally. And osteotomy resects part of the bone. The joint and the collateral ligament are reconstructed so as to avoid instability in the interphalangeal joint. And reduction of both the bony and tissue on the medial aspect of the great toe to create a more natural aspect of the thumb. Key point, the residual medial great toe skin flap is employed to cover the first metatarsal head with an acceptable dorsal result. MP joint arthrodesis is frequently performed to ensure stability and pinch to the new thumb, and secondary extension techniques include the palpoplasty. This is just a case which used this technique, and this was the donor site is closed primarily, and this is maintaining of the IP joint is important because this flexibility facilitates the nail pinch needed for fine manipulation. And the problem is the donor site. This was total great toe transfer. Also in the case like this, the new thumb is, I think, is good. The movement of the is not. The X-ray is good, but the problem is the donor side morbidity. This technique avoids the problem of the bone graft absorption, and I like the sentence, Buncke, toes make great thumbs. This modified technique, this modified procedure, the aesthetic advantage wrap around flaps while avoiding bone graft absorption and permeability. To minimize the complication, I believe that at least 1 to 1.5 cm of the proximal phalanx in the great toe should be preserved. Another possibility is this technique that I developed some years ago, is metacarpal lengthening and mini wraparound transfer. This patient refused the treatment toe technique because she doesn't want to have a complete amputation of the great toe. For this reason, I elongated the metacarpal using this external fixation. I have to wait for 2 months before having a new bone formation. And I removed the external fixator. I dipped the first web space using the Ostrowski technique. And 2 months later, thumb reconstruction was completed with a mini wraparound great toe transfer. And the final result that is not perfect because this work only with one joint, the carpometacarpal joint. And the carpometacarpal joint is responsible for all movement of the reconstructed thumb. But for this lady, the donor site result and the final functional result of the thumb was acceptable. And this is quite a similar case because this man had a spider bite and he lost completely the thumb. I elongated the thumb, but instead to wait for having a bone formation, I use a bone graft to reduce the time of treatment. And I opened the first web space with the posterior interosseous flap, that is my preferred flap. I don't like to put initially the skin graft over the donor side. I cover with Integra. I wait for 3 weeks, and I put a skin graft. In this way, the donor result is not too bad. And I remove K-wire, and the second time was the X-ray aspect, and I performed the mini wraparound flap for reconstruction, for the final reconstruction of this thumb. Also, in this case, I was not able to close directly the skin. I put Integra for 21 days. I remove Integra, I put skin graft, and this was the final result of the thumb, the donor side result, and X-ray result. Level 3 is thumb amputation proximal at the MP joint. In this case, the possibility is to use the second toe transfer, is transfer with the metatarsal phalangeal joint to function as a new metacarpal phalangeal joint. Left thumb amputation at the metacarpal head with soft tissue defect performed by Dr. Wu, covered initially with a pedicle groin flap, transfer the second toe. We have to remember that in this case, perextension joint of the second metatarsal joint was converted into flexion joint with osteotomy and plication of the plantar plate. And this was the final result. The integrity of the tenar muscle is essential for the success of this procedure. Aesthetic appearance of the second toe is less favorable than the great toe when transferred to the thumb position, but donoside morbidity is minor than with the great toe transfer. And with a standard great toe transfer, we have to perform oblique osteotomy at the metatarsal head of the great toe to convert it in hyperextension of the metatarsal joint into a flexion of this joint. But you have to remember that preservation of the entire length of the first metatarsal is just important as the reconstructed thumb. This is a case performed by Bernard McO'Brien, who was one of the cases performed in Melbourne, and he transferred completely the great toe, and the problem was the donoside. I think now a donoside like this is not acceptable. We don't recommend the transmetatarsal transfer of the great toe. In case of disarticulation of the metacarpal joint, the sacrifice of the metatarsal phalangeal joint causes major donoside morbidity. And the patient, I think, now cannot accept this type of donoside. Another possibility is the modified twisted toe flap technique. This technique combines the wraparound flap technique with the vascularized joint transfer and also tendinous flap based on the singular vascular pedicle. This was this case using the trimmed toe technique. This very nice case performed during my visit in Jinan, China by the group of Dr. Wang, one of the strongest microsurgical group that I have never seen in my life. Modified twisted toe technique reconstructs a very natural appearing thumb with good stability and strength together with a new great toe for the donor foot. And to maintain an intact skeleton of the second toe, another friend of mine, Dr. Wang from China, suggests to repair the donor side defect with a chimeric scalp, including iliac bone graft. Very difficult procedure to perform, also in a case like two flaps in the meantime. These techniques are not popular, especially in Europe among surgeons, because their procedures are more complicated and time-consuming. And finally, level 4. Second toe transfer, great toe after skin coverage, or modified twisted toe flap, or pollicization. I think pollicization is still a very nice technique. In most proximal amputation with absence of tenar muscle, the result obtained with toe transfer are, in the majority, are quite poor. This is a thumb amputation of the metacarpal shaft with comminuted fracture, covered with a grown flap, and 3 months later with transfer of the 6 months later transfer with the great toe. In complex defect of the thumb with unstable soft tissue around the tenar area, a preliminary flap is necessary to provide soft tissue. In most of the cases, I like this type of flap. This is a perforator flap from the radial artery without harvesting the radial artery, or maybe using a posterior interosseous flap, or maybe using a groin flap. In this case, I use a posterior interosseous flap, but it is possible to use a groin flap. It depends which flap are you more familiar. This is a complex reconstruction, the gloving injury, treated with a reimplantation of the skin, but I was able to replant only the skin from the finger. I have complete necrosis of the skin covering the thumb. 2 days after operation, arterial thrombosis occurred. I performed a debridement, and reconstruction was done with this big flap, reconstruct the thumb. And very interesting is I move the skin from the second toe to cover the first ray to improve the appearance of the donor side. This is another case of the glove injury treated with this type of flap, and the palmar skin was resurfaced using the free medial plantar flap. And the complication of flap failure. The most disastrous complication of the time transfer is flap failure, because I show some success, but I have also failure. The incidence of flap failure was reported in 0 to 7% of overall case. And the group of Taiwan team demonstrated that overall success rate of toe to thumb is in 363 cases was 98%. I don't have this type of success. This was most vascular compromise caused by arterial insufficiency within 72 hours following surgery. This was a case perfect at the end of surgery, but 3 days after surgery, we have this venous complication. And respiration should be carried out whenever vascular insufficiency is suspected. And this was after respiration. And this case was 7 days after surgery, 2 days after discharge from the hospital, and I came back to the operation theater, but I have completed thrombosis of the arterial system and the venous system. I tried many times, but it was impossible to restore the flow in the thumb. And I planned for disarticulation of the new thumb. But after 14 days after surgery, the thumb is not perfect. This was the result 20 days after surgery with infection, but this was the final result. It's not so beautiful, but the thumb is still present 10 months after surgery. And there is no clear consensus regarding how long blood flow through the primary vascular pedicle must persist to maintain flap viability. This was 10 years old boy due to manufacturing explosion. It was treated in emergency, and probably I performed the first mistake because I waited for 48 hours before planning reconstruction, and this was after 48 hours, 80 hours, and a lot of granulation tissue. The possibility to have infection was increased. This was at the end of reconstruction, but post-operative, I have infection, the skin was removed, and I covered with a reverse ulnar flap, and this was the final result. I was able to salvage this thumb. And this was another case in which I have infection, and I lost part of the pulp, and I decided to cover this with a pedicle taken from the middle finger without harvesting the nerve, including only the vascular pedicle. The nerve was left in situ, and the skin is very similar to the pulp, and the final result was not too bad. The donor site was acceptable in the middle finger, not a big scar, and the functionality was not too bad. To prevent complication of the toe-to-hand transfer, meticulous dissection and deligation of branch vessel, complete anastomosis of the vessel, and postoperative intensive monitoring of the transferred toe are mandatory. But I believe in most of the cases with complication, I have done a mistake. I have done an error. If I go in most of the cases, there is some mistake done by myself. Donor complications are categorized as a wound agent, infection, necrosis, scarring, or callosity, or pain or discomfort. And the complication and donor site morbidity have historically been underestimated, but they are present. And great toe transfer appearance to have higher morbidity rate compared with the second toe transfer. With second toe transfer, almost no patient complain about donor site morbidity. This was our recently paper that published that this was a work done by me and Dr. Wu from Korea, and this was our patients, our success rate in the patient until 2016 was 93%. And conclusion, I think it is important to include all the available technique and to suggest them to the patient, considering not only the level of injury, but also the patient function and aesthetic request. This is the only way in my mind to reconstruct a custom-made thumb. And despite the reconstructive available, the best results are obtained with reimplantation or revascularization whenever possible. and it is the surgeon's duty to inform the patient about different surgical options, microsurgical versus traditional technique, so that the patient can accurately choose their preferred one in terms of aesthetic and functional result. This is the only way to reconstruct a custom-made thumb. And in absence of any other proof, Isaac Newton told the thumb alone would convince me of good assistance. Thank you to the master of thumb reconstruction, Dr. Wu from Korea, Dr. Fu Chanwei from Taiwan, Dr. Morrison from Melbourne, Paco del Pinal from Spain, and also for Harry Buncke to open the way for thumb reconstruction. Thank you so much for very kind invitation. Great pleasure.
Wow, Roberto, thank you so much for an incredible talk. I've heard a lot of thumb reconstruction talks, and this talk, in my opinion, was definitely one of the best ones that I've heard. So thank you so much for that. I have a couple of comments, and then I'm going to open it up to some questions from the audience. First, I think you've really shown some incredibly beautiful results from an aesthetic standpoint. And your point that the hand is truly an aesthetic part of the body, second only to the face, I think is a very important point. And we, in fact, had an entire talk a few days ago by Dr. Joe Upton from Boston Children's, talking specifically about the importance of the aesthetics of the hand. So I want to congratulate, excuse me, I want to congratulate you on such beautiful results. I think that we pretty much agree with many of the things that you said with regards to not getting angiography unless there's a trauma or a congenital problem. In typical, we also prefer, typically we also prefer the great toe. I think aesthetically, it looks much more like a thumb, and as you said, Harry Buncke also said great toes make great thumbs. The question that I had for you is that there is a thought that in today's world, with the need for texting and computer work, from a functional standpoint, some people believe that the second toe may have a more functional advantage than a great toe because of its improved ability to be able to flex. What are your thoughts on the second toe with regards to function versus the great toe?
My impression is probably is there are some cultural difference, I think, between Europe and probably between Europe and Asia, or maybe Europe and the United States. Usually we don't perform so many cases a year. This means that it's quite difficult to force the patient for thumb reconstruction. Maybe a lot of patients don't want to touch the great toe or maybe the second toe. And if I show the result obtained with the great toe, maybe the patient can accept the result using the great toe. I think in Italy, one of the most important is functionality, but is very important, the cosmetic. And the cosmetic appearance of the second toe, it is the second toe. You cannot change the aspect of the second toe. The nail is different, the pulp is different. The cosmetic appearance of the second toe is different. This is the reason why, for example, people work with congenital anomaly perform the second toe in children. But in adult patient, I think it's quite difficult to propose the second toe. It's quite difficult to have a very nice cosmetic result. And the patient say, okay, the functional result is okay, it's not too bad, but the aspect of the second toe is terrible. This is the reason why it's quite difficult, in my experience, to have that the patient in Italy accept the transfer using a great toe, a partial great toe transfer, and more difficult to propose the second toe.
Mm-hmm. I would 100% agree with you. I think we don't do second toe transplants for the thumb. specifically for the reasons that you mentioned. The great toe looks much better, and even
Yes.
if the the flexion of the IP joint is not as great, I think
Yes.
it certainly looks a lot better. And I think what you have shown is that incorporating many of the techniques that you've shown by some of the other masters as well, you've really been able to maximize the aesthetic results of the great toe as well. And the results you showed were amazing. They were fantastic.
Thanks so much.
I'm going to call on Dr. Greg Buncke, who's online with us. Greg, are you there? You want to make a comment or question?
Hi, Roberto. Thank you again for a great talk. I've got to say, your results are absolutely stunning. They're beautiful. They look like thumbs. It's going to be something we're always going to be shooting for. The type of result that you have. One of the things that you commented on, which I just think shows the how nice a person you are, is that complications are all related to you. But you said something complicated. And I don't think that's what we all think. I think most of the time we always blame the complication on the patient or the nurses or the residents or something else. So it's very nice of you to do that. It's very nice of you to be that sort of person. But what I would like to ask, though, is we spend a lot of time, especially trying to get IP joint flexion, and many of us will try to do flexor tenolysis as a secondary operation, and do get some reasonable results. Have you found that you need to get flexor tenolysis on these patients to get IP joint motion secondarily?
Greg, in my experience, I don't remember to have performed a second tenolysis, because sometimes the result is not so perfect for the IP joint motion. But the patient, in the majority of the cases, is just satisfied to have, for example, 15 to 20 degrees of motion, and the patient in the majority of the cases refuse some other surgery, because the patient in Italy said, oh, you have already done first reimplantation failed, you have done microsurgical reconstruction, doctor, stop. For me, it's too much. And sometimes I propose just, for example, the wave plasty to have a beautiful result for pulp reconstruction. But sometimes the patient also refuses a very simple surgery like a wave plasty. And the patient says, no, stop, don't touch my pain. Stop, you have finished with me. This is probably the mentality that sometimes is, I think this mentality, this cultural background, I think is different between Europe and the people in Asia. During my stay in Asia, people accept not everything, but the word of the doctor is the doctor. In Italy, this is not more true. And we have a lot of medical legal problem. This is probably the reason why we don't force the patient to do some more surgery.
Understand. Same here.
I don't know if in the United States you have the same problem. I believe, I think.
We do.
Yeah, it's very similar. It's very similar here, and I think I would definitely agree with you with my travels to the Far East. I think that there are a lot of cultural differences, and whatever the doctor says, the patient is okay with that, and they're willing to go through that. Professor Balakrishnan from Chennai, I saw that you turned your webcam on. Did you have a comment or question for us?
No comments. It's only say hello to Adani.
Nice to see you.
How are you? Right,
Hi, thank you. You?
Very nice to hear you after 20 years. Excellent. Safa, thank you. Thank you for bringing me. Thank you very much.
Great. Thank you for joining us.
Thank you so much for listening to me. Thanks so much, Professor.
Thank you.
And Roberto, I wanted to thank you again. I think this was truly a tour de force of thumb reconstruction, and I'm delighted that you were able to share your experience with us. And I'm also very happy that many of the people that you mentioned in your talk either have already given us talks as well, virtually or are on the schedule to give us talks, like Dr. Wu, Professor Wei, Paco Pinal. All these guys have already given us or will be giving us talks, so I'm very excited about that.
Thank you. Thank you so much. I would like to congratulate, because you are still one of the strongest team in the world, and thanks so much for giving me this very nice possibility. Thanks.
Great. Thanks again. And I can't wait to visit Modena again. It's truly a beautiful, beautiful place. And I think I want to encourage everyone who's been on this call to visit Professor Adani at some point. It's really a beautiful part of the world, and obviously a master surgeon. Roberto, thanks again. And I look forward to seeing you in person soon.
See you soon in United States.
Okay.
Okay.
Thank you so much. Take care. Bye-bye.
Thank you so much. Bye.
Bye.